guys so much for being here. It's the last day on a conference during lunchtime, so we really appreciate your time. My name is Alex Monroe. I'm an assistant professor in the Departments of Emergency Medicine and Pediatrics at Emory in Atlanta. My co-presenter here is Tom Hardy. He's a third-year neonatology fellow at the Medical University of South Carolina, and will be joining the Emory family in June after he graduates. We have no disclosures. So I'm going to kind of set a scene for you here. So imagine that your charge nurse comes running up to you, and she says, "Hey doc, there's been a precipitous delivery in the parking lot, and the baby's not doing great." So how many of you, with a show of hands, have kind of a visceral anxiety reaction to this? You get a little bit nauseous, your heart rate spikes, a little bit sweaty. Yeah, and then how many of you would feel prepared to take care of that baby? Okay, and if you were going to try to take care of that baby, how many of you would think that like PALS is the way to do it? Just start with your PALS algorithm. It's not the worst, but it's actually, there's a lot of conceptual differences between PALS and neonatal resuscitation that we hope to kind of highlight for you here today. So over the next 20 minutes, we hope to show you how adding neonatal resuscitation to your toolbox can help decrease some of that anxiety and make you more confident and prepared when caring for some of the world's smallest patients in order to have better birthdays. Given the brevity of this talk, we're going to be focusing on the why, the what, and the how. Of note, this is not meant to be a supplement or in place of taking a neonatal resuscitation program or NRP course, but more to highlight the differences and the kind of gaps in training between faculty and trainees when it comes to neonatal care, as well as give you some ideas of how to improve that and close that gap. So if you take nothing else away from this lecture, I want you to kind of remember these 4 things. First, this is a birthday. It's a big deal for both the parents and the baby, so celebrate a little bit. Say happy birthday. Take that moment also to take a deep breath yourself and kind of get a little bit of centering because it's a high-stress environment. For almost all babies, sick and not sick, starting with the basics of warm, dry, and stim is going to get you really, really far in caring for that baby. For the ones that need a little bit more help, remember that neonatal resuscitation is focused on establishing ventilation, not focused on compressions or circulation. And the thing that trips up a lot of emergency physicians is that our target vital sign that we are trying to address is actually the heart rate, not the SpO2, which is a bit of a cognitive disconnect given that we're trying to target ventilations. And so unless you were interested in pediatrics as a trainee or have had children yourself, most of your trainees or you have not actually seen a brand new baby in a really long time and don't know what they look like, but they almost all come out with some degree of blue discoloration around their hands, their feet, their face. This is actually Tom's son, Thomas, when he was born. And that's a totally normal finding. And they can stay blue and have issues with cyanosis for an uncomfortably long amount of time. So they won't actually reach their preductal target saturation where we would consider it to be normal until they are 10 minutes old. So this is one of the big reasons why we don't actually target an SpO2 as our vital sign of choice. Of note, we're using a preductal saturation, so that's our right wrist, if you need help with that.
I can assure you he's neurodevelopmentally appropriate 18 months of age, so that was a routine resuscitation.
So additionally, another primary goal of NRP is actually to help facilitate that transition from intrauterine life to extrauterine life, and we're going to do that by focusing on ventilation, not circulation. A little bit of physiology on why we do that. So when the baby's in utero, they're getting all of their oxygenation through mom. Their lungs are filled with fluid and clamped down, and they're getting that circulation to the rest of their body through the ductus arteriosus. As soon as they're born and that cord is clamped, there's no more oxygen supply from mom. And so you need to establish oxygenation, open up those lungs in order to decrease your pulmonary pressures, decrease the strain on the heart, and allow your heart rate to actually establish adequate perfusion to your brain and body. This is another big way in which NRP is different than our PALS algorithms, and why, again, we're focusing on heart rate and not SpO2 as our vital sign of target. So the good news is that for almost all babies, If you do a little bit of warm, dry stim, they're going to start crying, and you're going to be fine. Basic neonatal care with these items is pretty easy. It's usually what's included in your born on arrival kits that you should have in your emergency departments. Some form of a blanket, suction, a hat to keep them warm, and clamps for the cord. If you can wipe that baby dry, suck out their nose and mouth, chances are they're going to get really mad at you and start screaming right away. For the ones that need a little bit more help, it's important to know the tools that you have in your department. So most people have some form of an infant warmer tucked into like the corner doldrums of their ER that they've never looked at or touched before. So here's a short video to try to get you some orientation to it. Of note, these things take forever to turn on and boot up. So I want you to take note. So we just turned the power button on. I'm going to talk for another like 20 seconds, and then it's going to be ready to use. So the first thing you hear about a baby coming into your ER, hit the power button. In the meantime, attach your EKG leads, your pulse oximeter, start setting up your T-piece resuscitation, and maybe do a pre-brief with your team to kind of establish roles and use that time effectively. It is still booting up. Awkwardly long amount of time. But once it gets to this page, you'll hit the Admit Baby button, and it'll bring you to the temperature management screen. Most of the time, you can stick on a manual mode, so just start at 100%, get that baby warm, keep that baby warm. There is a lower limit of 25% power that you can do, and it won't go below that. There's also dynamic temperature monitoring, so if you hit toggle the mode here, you can actually set a temperature to 36.5 or 37, and attach a temperature probe to the baby's skin, and it'll automatically adjust the temperature or the power that it's giving to maintain that temperature. In addition to that, you can actually use your infant warmer as a pressure-controlled ventilator. So the first thing you're going to do is connect your T-piece resuscitator, set your FiO2 to room air, 21%. You're going to want to set your flow rate to 10 liters per minute using this knob here. And then finally, you'll set your peak inspiratory pressure using this knob here, or your PIP. We'll kind of talk to you about how to adjust that. The PEEP is adjusted on the T-piece, which is this piece of equipment that you see here, by adjusting the knob on the top. And then when it comes time to give breaths, you can assess your PEEP or your CPAP by occluding the mask with your hand and seeing what pressure you get on the manometer there. And then as soon as you occlude the top hole of your T-piece, you're actually delivering a breath. And so that's going to show you what your positive inspiratory pressure is and help you adjust your pressures from there. Okay, so now I'm going to hand it off to Dr. Hardy.
Hey folks, thanks for having us here today to talk about a subject that's obviously very near and dear to my heart. First, let me say, I'm not jealous of the alphabet soup that you all have to keep track of as emergency medicine physicians. ACLS, BLS, PALS, all quite complex, especially when compared to NRP, my world. In neonatology, we like to follow the KISS principle, keep it simple. As you can see here, this is the 8th edition NRP algorithm. This is all it is. It's very streamlined, very straightforward. But there are some few key differences, as Dr. Monroe touched on, that we'll go through today and hopefully give you a little bit more tools and make you a little more comfortable and maybe make the situation not as nightmarish as we just explained it to be. We're going to break down those key differences into assessment, intervention, medications. So we'll start with assessment. Much like the primary assessment of a trauma patient with ABCs, we use the 3 T's in neonates: term, tone, for lack of a word with T, talking. And if the answer yes to those questions, keep the baby with mom, go on about your day, have another coffee, do whatever you need to do. If you answer no to any of those questions, the baby needs a little bit further assessment, a little bit more tune-up. As we touched on, the kind of hallmark, the most important aspect of resuscitating a newborn is establishing good ventilation, establishing respiratory support. So the first thing you're going to assess is how effectively they're breathing. If there's any apnea or gasping, the heart rate's less than 100, which is really a marker of inadequate respiratory support, you're going to need to do some intervention. And as Dr. Monroe touched on, heart rate is going to be the vital sign that guides the effectiveness of our interventions. You're going to primarily use electrographic monitoring to monitor their heart rate. In an active resuscitation, as you all probably know, auscultation and palpation kind of unreliable in a code scenario. But I will give you the tidbit. Probably the best place to palpate a pulse on a neonate is actually at the umbilical cord. It's still pulsing even after the cord is cut. If the heart rate's less than 100, that's going to trigger one cascade of interventions, and if it's less than 60, that's going to be another cascade of interventions. So, brings us to our next section, interventions. As I already touched on, supporting ventilation is the paramount intervention in resuscitating a newborn. Save your chest compressions for later. We'll talk about those, but I really cannot stress enough how important being able to provide good PPV to a newborn infant is and be able to resuscitate them effectively. So, when should you be looking to provide PPV? As I already said, if there's any signs of inadequate respiratory effort, you should be moving to providing PPV. If there's apnea, gasping, heart rate less than 100. How are we going to do that? I'm sure you're all familiar with the flow inflating bag. Let's see if I can figure out the laser here. The flow inflating bag, self-inflating bag. This is, as we already touched on, the T-piece resuscitator that we commonly use in neonatology and the NICU. It's a little bit more specialized device. You can provide CPAP and PPV, vary your I time much more easily just by occluding the hole for a different amount of time. It does have a little bit of a learning curve, and so I would encourage, if this is something you want to incorporate in your practice, to get some hands-on time with it, either in a sim lab or for the learners out there doing a rotation through the NICU. And the rate, the administration of breath, as you probably would expect, neonates breathe at a much faster rate than adults. So you're giving it, that we refer to it as the neonatal waltz. It's a breathe 2-3, breathe 2-3, which is approximately 40 to 60 breaths per minute that you should be giving these rescue breaths. So in order to give good PPV, probably the thing you have to be strongest at is troubleshooting when it's going wrong. NRP uses the Mr. SOPA mnemonic device to guide those corrective steps. M and R, the first two steps, you're repositioning the mask, getting a good seal, you're repositioning the airway. It's important to clean the face off and remove any secretions or amniotic fluid, as that fluid can cause you to have a bad seal, and give a shoulder roll. Sure, maybe some of y'all probably remember the baby has a big occiput, can occlude their airway very easily. Oftentimes they get occluded with secretion, so suction that airway out, bulb suction, catheter suction, both work well. And open the mouth up so that you get better access to the airway. Sorry, didn't mean to skip forward.
Yeah, I have to.
Apologize for the technical difficulties.
Premature advancement, sorry.
A little.
Of note, one of the things about this video is the MRSNO, you sort of do all of that within your first 30 seconds. And even just in this video, when we demonstrate them, that's done in 20 seconds. So you can imagine that you're kind of doing all of these simultaneously. It's a lot of the stuff we do to troubleshoot airways to begin with anyway, but to just kind of have your algorithm of how am I going to make this better.
Yep.
It's pretty quick. You want to give your ventilations a good 30 seconds after that to see if they'll take effect by monitoring that heart rate afterwards before moving on to your next steps, which is where we'll pick back up.
If anything, repetition is key, right? So you just went through all that already once again, so now you're all experts. So if those first 4 steps are ineffective at producing good air entry, chest rise, you want to increase your PIP increments of 5 to 10 up to 40. And finally, if the first 5 steps are ineffective, you're going to look to establish an alternate airway, preferably with an ET tube, though they do make LMAs small enough to fit term and late preterm infants. And I'd just touch on, make sure you have good personnel there, because as you saw me fumbling with the T-piece resuscitator, it's not easy to do by yourself. Oh, and I think I forgot to mention, we do this without RSI meds, so you can intubate emergently in these infants and you don't have to wait on the medications. So if you've gone through all your corrective steps and you're providing adequate ventilation, you get good chest rise, you got good air entry, and your heart rate's still less than 60, now is the time to give chest compressions. So chest compressions are given about the same rate as the other algorithms. 90 per minute is what NRP states, and the difference is you're coordinating those chest compressions with breathing as opposed to giving them simultaneously. So that rate's 1 and 2 and 3 and breathing, 1 and 2 and 3 and breathing, which is one cycle every 2 seconds. For those that are keeping track of the numbers, you should have an alternate airway established at this point. You should be increasing your oxygen to 100% at this point in the resuscitation. So now we get to some of the medications we use. There's very few. I'll cut to the punch. In fact, so few that I'm using the term loosely here. Oxygen is probably the most commonly used medication. And I say that because we're very keenly aware to the toxic effects of oxygen in the newborn. So we try to keep the oxygen within these parameter goals that Dr. Monroe already discussed with y'all. The next most common medication is good old epinephrine. I'm sure you're all quite familiar with it, familiar with the weight-based dosing from PALS. Preferentially, we're going to want to give it through the IV, though we can give it through the ET tube. The IV access is usually emergently established most easily through the umbilical vein, another procedure that you may want to refamiliarize yourself with. And then in special circumstances such as placental abruption or umbilical cord prolapse, there may be, the infant may be in hypovolemic shock and fluid expansion might be necessary. Neonates are susceptible to rapid fluid shift, so we use a 10 ml per kilo bolus instead of 20 ml per kilo you would use in your other pediatric patients, and that's given every 2 to 5 minutes. So, lastly, I want to touch on a few special circumstances that probably are the most frightening. The extremely preterm infant, probably the most common part of my job. They have very thin skin, they have low temperature reserve, so they're very susceptible to cold stress, insensible loss, so protecting them with some kind of impermeable membrane, saran wrap can be used if there's no, if the plastic wrap is not available. And then making sure that you have the radiant warmer set up or a thermal mattress to help keep their temperature supported. There's a few congenital anomalies that need some special consideration. The first one I want to touch on is diaphragmatic hernia kids. This is the one case where you actually want to avoid giving PPV because insufflating the bowel and the chest can actually further exacerbate the physiologic compromise that's already there. I'm not saying don't do it because there are some circumstances where you can't get the advanced airway established fast enough, and PPV may save the kid's life, but it would be nice to avoid doing that. And then infants with abdominal wall defects, neural tube defects, they have exposed anatomy that's obviously increased risk for injury, so make sure to position those well, protect those well. They do have increased incidence of water loss as well, so keeping an eye on that if you're supporting these kids for longer than just the initial resuscitation. And then finally, touching on when to call for help. Simply put it, whenever you think you need help, we're always there to help either by phone or in person. And also on that note, get to know your NICU resources and where we're coming from and how long it takes us to get there so you can mobilize us in an appropriate manner. Hand it back off to Dr. Monroe.
All right, so now that we've gone through our whirlwind tour of neonatal resuscitation, I just want to summarize some things for you. So again, this is a big day for the parents and the baby. It's a big day for you. Take a moment to celebrate. You'll go a long way with the basics of warm, dry stim, but if you find yourself in trouble, focus on establishing adequate ventilation and do so by targeting that heart rate. If you're interested in other ways to have better birthdays and are looking for a little bit more information, the 3 pieces of kind of advice that we would recommend is 1, get to know what you have in your shop. Some people have infant warmers, some people don't, some people have BVMs, some people have a T-piece resuscitator. So just being familiar with the tools you have available to you can decrease a lot of the stress that you're going to be feeling when it comes time to actually use them. In addition to that, the American Heart Association and American Academy of Pediatrics do have a formal certification course in this. You could consider, it's a day-long course, you could consider taking it yourself or potentially sending your trainees through this course as they go through their sort of intern orientation. For people that are in maybe low and middle income countries or maybe less highly resourced settings, the WHO and AAP also have the Helping Babies Breathe program, which follows more of a train-the-trainer model and might be more sustainable kind of worldwide. And finally, our last kind of push here is to say, consider incorporating exposure to neonates into your training curricula. take that month that you have for OB and labor and delivery and split it into two, where they do 2 weeks of deliveries and 2 weeks of actually following the baby afterwards. Or consider swapping out your pediatric ICU rotations or part of your pediatric ICU rotation for part of a NICU rotation. There are some people, even if you just did it as an elective that was available to trainees in their second or third years, these are the high-risk delivery teams are pretty high yield procedure months, so lots and lots of intubations, even just for in and out surfactant, lots of central line practice through the umbilicus, lots of chest tubes, and just like exposure to itty-bitty babies and what a preterm baby looks like can really help decrease a lot of the stress. It was one of the most high-yield things I did in all of my training as part of my fellowship. So that's all we have for today. We'd welcome any questions or feedback. If you don't feel comfortable talking in front of the room, you're welcome to scan this QR code. It will take you to a brief survey. If you leave your contact information, we can give you some answers to your questions that way. And then finally, we just want to say thank you again. I'm Alex. I'm at Emory University. This is Tom. He will be joining me at Emory. And the majority of this talk is just based off of Neonatal Resuscitation algorithm textbook, which is available at all your local bookstores and Amazon places. Hi. Do you want a microphone?
Oh, sorry. I just like in the community hospitals I work at, that's like my biggest fear.
Yeah.
So if mom comes in and the baby's delivered and like because none of the equipment is ever where it's supposed to be and
Sure.
you're just like waiting on equipment,
Mhm.
should you wait to clamp the cord? Because the cord is their source of oxygen.
So if the placental circulation is still intact, you can delay cord clamping, but if she's starting to deliver the placenta, the NRP recommends no more than 1 to 2 minutes of delayed cord clamping, because after that it's tough to know, how intact the placental circulation is. So it's reasonable to do some delayed cord clamping. But if you don't have a radiant warrant, really knowing where your BBM or your TP's resuscitator is probably the one piece of equipment
Yeah.
to make sure you have close on hand.
Most people have that born on arrival kit somewhere that's like easy to grab and go, and so I would make sure that you have one of those in your ED if you don't already. And then the biggest limitator or limitation that probably we're going to have in the EDs is not so much whether or not you have an infant warmer, but actually whether or not you have a mask that's small enough to fit a neonate. And so that's kind of the other critical supply piece I would make sure that you have in your ED if you're in a place where you don't have the rest of the bells and whistles. Sure.
Yeah, you can place an IO in even the extremely preterm infants. Obviously, that you need to make sure that you're measuring appropriately and doing it appropriately. But it is a procedure included in NRP is a possible way to establish IV access.
The caveat there is that it's manual because their bones are so itty bitty and brittle. If you try to use a power drill, you're going to go right through and break it.
What
site?
Site where the tibia.
And then this is just we anticipated some access questions. And so umbilical access is kind of the mainstay of neonatal resuscitation. Many people are not going to feel comfortable placing an umbilical catheter like central line. That is part of NRP, so if you're interested in getting some experience with that and some sim experience, they will include it in the course. But if you find yourself in a pinch, if you get a really long angiocath and try to feed that in, as long as you're getting blood return, you can use that in a temporizing measure.
Yeah. And in resuscitation, you're establishing access emergently, so it's not a clean central catheter. So you're actually not going to place a central catheter you're just going to place it into the ductus venosus where you get blood back, and then you'll replace that you'll replace it under sterile conditions later with a more appropriate catheter.
I think we're close to time, but we'll take questions until we get kicked out, unless there are none. Yeah?
If you can't figure out the positive pressure ventilator connections, nobody uses the baby warmer.
Yeah.
Can you just bag them? And is that
Yeah.
enough?
Yeah, so you can bag them. The trick with bagging, and my residents are leaving now, but they can probably attest to this, is that, because I make them run through a sim, is when you're doing it at that rate of 40 to 60 breaths per minute, it's a lot on your hand. And so you'll end up with like almost a claw hand because you're doing breathe 2, 3, breathe 2, 3, breathe 2, 3. And so if you can use the TP, like if you have that and you can learn it, that's great. The one piece of advice I would say that I've learned from doing these sims is actually switch out your person bagging, much like you would do with chest compressions, because their forearms are going to get like wrecked. But that's a great question too. Yeah.
How long do you run these kind of figure out it's not going to be successful because you go like this is a drop off? It's really not.
Yeah, excellent question. There's actually been a change recently. It was 10 minutes of resuscitation time. It was what the NRP guideline cited, and with the 8th edition, they've increased it to 20 minutes because they've found that most resuscitations actually go longer than we realize. I'm sure y'all are probably pretty familiar with how fast time can pass by. So 20 minutes is the kind of upper echelon. If you're not seeing improvement in heart rate at that point, NRP says it's reasonable. They do make a caveat to say that if you as a physician with discussion with the family feel that your efforts are futile sooner than 20 minutes, that you can end the resuscitation sooner than that 20-minute cutoff. So you don't have to go to 20 minutes. That's just kind of the guideline they've put in place. But excellent question.
Well, thank you all for being here. We really appreciate it.